Welcome to MedEd's production of the CNOR Exam Review. My name is Molly McBrayer, and the title of this module is Perioperative Patient Assessment and Diagnosis. This is your objective. You earn continuing education credit for this activity. I'm not going to read the objectives to you, but this cartoon is pretty funny, I think. It says, I undressed already to save us both some time. And I'm sure our patients feel like that, as rushed as we are constantly getting patients ready for surgery, doing surgery, and kicking them out the door with a smile on their face after surgery. So there are two different assessments related to perioperative nursing practice. There's the Preadmission Assessment, and then I'll talk about the Preoperative Assessment. The Preadmission Assessment is based on criteria and guidelines that are identified for all peri-anesthesia care settings. Preadmission telephone calls or face-to-face interviews are conducted by an RN prior to the patient ever coming into the facility. And that's based on pre-established criteria, really differentiating the need for those patients that need to be seen face-to-face versus those patients that other forms of media, including telephone calls, may be used to gather the information that's necessary in preparation for surgery. So the components of the pre-admission assessment may include all of these. The baseline physical assessment that may be garnered from the surgeon's office or the clinic in which the patient was seen prior, any allergies, cultural, emotional, social, economic assessment. If you're doing surgery such as a total hip on a patient, you need to make sure what support that they have, where they are going to be going after surgery. Are they going to go to rehab? Can they afford rehab? If they're wanting to go back to their home setting, are they able to afford home health if their insurance isn't going to cover all of that? Do they have the adequate resources at home to go back to that setting? You also want to look at their medication history, and that includes any over-the-counters like herbals, dietary supplements, any illicit drug use, including alcohol abuse or alcohol use. Their anesthetic history, including any local that they've had, perhaps like at a dentist office, or if they've gone to a dermatology clinic, or even if they've had moderate sedation, perhaps if they've had an endoscopy procedure before and they've received moderate sedation. Results of any testing that's been ordered prior to. And then, of course, as I said before, looking at discharge planning, any referrals that may be necessary, and identification of physical alterations that will require support in and after surgery. So the pre-admission testing incorporates lots of teaching, what medications should be taken before surgery, if they need to do preoperative showering, if they need to be NPO, and at what time frame based on your hospital standards. Because not all hospitals follow the American Society of Anesthesiologists and the NPO guidelines. For your knowledge, although it doesn't usually, it's not usually asked on the CNOR exam, but NPO status for adults is no solids for 2 hours prior to surgery. And so clear liquids up to 2 hours prior to surgery, and no solids, sorry about that, for 6 to 8 hours prior to surgery. Research has shown, and why the American Society of Anesthesiologists accepted that as the norm for NPO, is if somebody continues to drink clear liquids up to 2 hours prior to surgery, that they have actually less gastric residual than if somebody that has been NPO for 8 hours, 12 hours, 16 hours. And so again, as a correction, no solids for 6 to 8 hours for adults prior to surgery, and nothing to drink for 2 hours prior to surgery. So informed consent, you're looking at advanced directives. Development of that plan of care actually starts in the pre-admission assessment. And then documentation, because we want to be able to communicate all of the information that we gather for all of the team members. So the preoperative assessment then is conducted the day of surgery by a registered nurse. And that's actually Joint Commission that mandates it is a registered nurse that does the preoperative assessment on the patient the day of the surgical procedure. The assessment, documentation, and communication of the patient's status is communicated to all members of the healthcare team. And then you do have to have assessment for special populations. Special populations are going to change based on the individual facility. For example, if you're a children's hospital and all you do is take care of children, yet you have a child that has tracheal atresia, and that child has been coming to your facility, going directly to the ambulatory care where they're gotten ready for the procedure, gone to the endoscopy suite or the OR to have the procedure, goes back. They've formed relationships over the years. They know everyone. You know their family. They know your children. And so it's an ongoing care setting for the patient. So when the patient turns 18 years of age and by our healthcare standards becomes an adult, they're not just going to automatically go to an adult hospital for their dilatation, for their tracheal atresia. They feel very comfortable going to that pediatric hospital and will continue going to that pediatric hospital. But now, when the patient comes in, they're an adult, so you have to have a special assessment for that population. That's just one example. It's a little extreme example, but it actually does happen in children's hospitals every day. So the goals of preoperative assessment, there are many. So we want to optimize patient care, their satisfaction and comfort, minimize perioperative morbidity and mortality, and we want to assess the factors related to anesthesia and the anesthesia care plan. We also want to minimize surgical delays and cancellations, ensure accurate communication between the patient and all healthcare providers, evaluate the patient's health status, and then look at what testing is needed and make sure that we have all of that documentation for the results of testing, including any consults that may be needed. So patient care, one of the things I hope that you remember out of all of this review course is research has proven that the patient will have a better surgical outcome if the time spent during the pre-admission phase is used to earn the patient's trust, to answer the patient and the family's questions, and give directions as far as the expectations for the day of surgery and the immediate time post-operative. So you really need to take a few minutes and concentrate on that patient, answer all their questions, make sure they feel comfortable, earn their trust. So the patient and the family interview, introduction, brief explanation of your role in getting the patient ready. You have to remember to really look at the nonverbals, so eye contact, posture, physical gestures, and that includes not only your eye contact, your physical gestures, your posture, but also the messages that you're receiving from both the patient and the family. And you want to present as a professional, credible nurse and really take that time to ensure that the family and the patient know that you're there to take care of them for that amount of time. No one else in the unit means anything to you except that patient and the family right in front of you. So patient identification, of course, is part of Joint Commission National Patient Safety Goals, and you need to use two identifiers. So Joint Commission doesn't say specifically what those identifiers have to be. That's up to your individual organization. However, it does have to be consistent throughout your entire organization. So many times organizations do choose the patient's name as one of the identifiers, and that is because most patients know their own name. And then many organizations also choose date of birth because many patients know their own date of birth. However, that's not the only data that you can use for patient identification. You certainly could use a medical record number. You could assign a specific number to the patient. You could use part of their social security number, like the last 4 digits or the first 2 and the first 4. So your organization actually chooses what the 2 identifiers are. What Joint Commission says specifically is that we cannot use the patient location or the patient diagnosis for identifiers. So you can't say, oh, the gallbladder down in room 5. That's not appropriate patient identification. So the history and physical. Many organizations perhaps make this a little bit more difficult than what Joint Commission requires. And what's important is for you to know specifically what the Joint Commission standard is related to history and physical. So sometimes you've got to get outside of your little silo of practice and really broaden your knowledge level in order to be successful on the CNOR exam. So what Joint Commission says is that a history and physical cannot be dated any later than 30 days. So it's not a month period of time because we do have those months in which we have 31 days. So no older than 30 days. And what they also say is that there has to be a review of that prior to any procedure and any changes documented. We also need to have the history and physical and that portion of the update that is done immediately prior to the procedure. We have to have that signed, dated, and timed. That's what's considered authentication. So the surgical consent. Your organization, again, determines the length of time for the surgical consent. A consent is a voluntary act in which one person agrees to have another person do something to them. And for medical liability purposes, we like consents to be in writing. However, that written piece of paper is not the informed consent. Prior to a patient actually providing informed consent with the surgeon or the proceduralist, there are specific areas in which have to be discussed between the proceduralist and the patient, or the surgeon and the patient. And those areas include the description and nature of the procedure, any alternatives of treatment, and the relative risk related to those alternatives of treatment, possible and risk involved with the procedure, probable results, including any problems of recuperation and time of recuperation anticipated, and then the consequences associated if the patient does refuse treatment. So these 5 elements are what actually provide informed consent, and it is the surgeon or the proceduralist that is responsible to get informed consent. There are exceptions to informed consent. They vary among all of the states, so you do not need to know specific exceptions within your state because this is a national test, so you won't be tested on the specifics for your state. What you do need to understand about exceptions to informed consent are emergencies. So any life or limb emergency is considered an exception to informed consent. Now, many organizations have a specific policy in which that is documented. How many surgeons have to document that this is truly an emergency, how many providers have to document that, how it's documented, when it's documented, where it's documented. That's all very specific to your facility. And again, you won't be tested on that. What you need to understand for the CNOR exam is that any life or limb emergency is an exception to informed consent. So then the anesthesia evaluation, the anesthesia care provider actually provides and looks at the needs to complete an evaluation prior to surgery, unless the patient's having local anesthesia. So if the patient's having a straight local anesthesia that will be monitored by a registered nurse, or excuse me, if the patient is having moderate sedation and will be monitored by a registered nurse, then the anesthesia care provider is not going to do an assessment on that patient. When anesthesia does an assessment, they're looking at the patient's past and present medical and medication history, any previous anesthesia, the ASA classification, and they're providing and developing an anesthesia plan of care. So pre-anesthesia assessment includes the review of systems to detect any abnormalities of major organ systems, any previous anesthesia history, including any sedation history, as I mentioned earlier, alcohol, any substance abuse. You got to remember, patients are always going to minimize their use of alcohol and substances. The psychological history and support that the patient has. NPO status, as I already said, solids is 6 to 8 hours, clear liquids is 2 hours. Any labs, perhaps chemistries, hemoglobin, PT, PTT, and there could be many others in addition to that. Their vital signs including their weight and their O2 sat, any allergies, their current medications, including prescribed, over-the-counter, herbals, vitamins, supplements, homeopathic treatments that they provide. Now, smoking history, how many packs per day and how many years have they smoked? Smoking, as we know, has a lot of negative effects. There's negative effects on cardiac function. They have hypoxemia, so low oxygen concentration after surgery, even before surgery, but especially after surgery. Their airway is more irritable, so they're at higher risk for bronchospasm, perhaps even laryngospasm, and they have an increased risk of atelectasis and postoperative pneumonia. However, smoking, there is less incidence of post-op nausea and vomiting. So it does have one benefit to it, but certainly not to outweigh all of the risk and the problems associated with smoking. The thing that you have to remember, smokers cough a lot when they're usually emerging from anesthesia. And so coughing will increase intracranial pressure. It increases intraocular pressure as well as intra-abdominal pressure. And patients really need to refrain from smoking for 8 weeks or more to decrease those cardiac effects, especially related to the smoking. So I don't know about you, but it would be nice if our patients refrain for 8 minutes prior to sometimes, let alone 8 weeks. So cardiovascular assessment, what implantable devices does the patient have? Any pre-existing disease like hypertension, angina, coronary artery disease, previous MI, valvular dysfunction, dysrhythmias, conduction problems. How severe is their treatment, or how severe is their disease, and what prior treatment have they had? And what signs and symptoms do they have? Can they do their activities of daily living? Are they able to take a shower without getting winded? Can they go up a flight of stairs? Do they have angina, pressure, syncope, shortness of breath? And then pulmonary kind of rolls right into that. Do they have a history of asthma? Do they have a history of COPD? Have they been a smoker in the past? Of course, do they smoke currently? Any recent upper respiratory tract infection, bronchitis, pneumonia? How often do they use their rescue medication, their inhaler for their treatment? What's their cough like? How severe is it? What type of cough? How frequent do they have the cough? Is it on a continuous basis? Do they just have it in the morning, in the evening? That can give you some clues as far as what is pathologically going on with the patient. And do they produce sputum? What color is it? The consistency of that. Is it bloody at all? What's their exercise tolerance? Again, can they go up a flight of stairs? Can they walk out to their mailbox and get their mail without getting short of breath or having dyspnea. How many pillows do they sleep on? Or are they sleeping in a recliner every day? Do they snore? Do they get respiratory attacks? And what triggers those? How often do they get those? And how severe are their respiratory attacks? So then airway assessment, one of the things that we look at is, certainly asking, do they have sleep apnea? Do they snore? Do they have stridor during sleeping or awake times? Do they have some of those dysmorphic facial features like a small receding chin or a short neck or increased circumference of the neck? Do they have advanced arthritis that they don't have as much range of motion? Are they significantly obese, and are they carrying that obesity in the truncal region, in the upper body region? Do they have limited extension? What is their mouth opening? Do they have a small mouth opening? Do they have loose teeth? What about their uvula? Can you, when you're assessing for the Mallampati airway classification system, can you see their uvula like as in a class 1? Or is it totally gone and you're unable to see their uvula when they stick out their tongue and say, ah, and they have a class 4 when it's totally not visible? And this slide actually portrays the Mallampati airway classification when the anesthesia care provider has a laryngoscope and they're actually looking at those vocal cords. And so in a grade 1 Mallampati airway classification, you see the full vocal cords, a nice full opening, going all the way down to a grade 4 where it is just literally a black hole. You see nothing at all with a grade 4. And typically someone that has a grade 4, whether it would be the non-visible uvula when assessing preoperatively, or if they didn't realize the patient had significant blockage of that, then they're usually going to do an awake intubation on that patient. That's one of the main reasons, when they've got to make sure that the patient's able to control their own respirations before they put that patient totally asleep and then try to intubate them. So pain assessment. Joint Commission does require that we do a pain assessment on our patients preoperatively. We want to educate the patient regarding the pain scale that we're going to use and give them some definitive definitions about that. 0 being absolutely no pain whatsoever and 10 being the worst pain of your life. You couldn't crawl out of a building if it was on fire. So giving them some certainly definitive instead of just 0 to 10. Most patients are going to typically overrate their pain. There are a few age categories in which they will not overrate their pain, especially adolescents. So in that puberty stage, those adolescents tend to really underrate their pain significantly. So patient and family support, again, just remember to take a few minutes, use that direct eye contact, assure the family and the patient that the patient will not be left alone. You might not be with them the entire time, but assure them they will not be left alone. And then really concentrating exclusively on that patient for the time that you're with them. Try to avoid any interruptions in the care of that patient and really concentrate on them. So you were hoping you never saw this again in your life. Of course, this is the nursing process. We were all taught the nursing process when we were in nursing school. And believe it or not, you do function in all of these areas every single day. And many people have a hard time realizing that. So I think this is especially one of those areas where flashcards are going to help you immensely. And make some flashcards, put the actual area of the nursing process, for example, assessment, on the front. Put the definition of assessment on the front, and all that is data collection of the front of the index card, and then start writing down examples as you go through of how you actually gather data on your patient. So that'll make that process very solid within your experience range. when you actually harness those examples specifically. So assessment is data collection. Planning is the necessary steps to achieve the goal. And then for nursing diagnosis, we use all NANDA approved. So it's North American Nursing Diagnosis Association. And so we use all NANDA approved nursing diagnosis. Now, quite frequently, what happens is nurses do utilize nursing diagnosis. They just have a habit perhaps of checking boxes, whether that would be on your electronic medical record or checking boxes if you're still on paper charting. And so you're not really paying attention to those a whole bunch. And what I would challenge you to do as you are preparing to take the CNOR is really look at those. Look at the options that you're given among all the different areas. So look at the options for the preoperative area. Look at the options for intra-op. Look at the options for post-op. And there's probably about, at a max, about 10 different nursing diagnoses that are used within all of perioperative nursing. And those are the major ones. Certainly we can use a lot more than that, but there's about 10 major ones. So take a look at those, really jot those down and have a good understanding so that when you are asked questions on the CNOR exam, and I can absolutely guarantee you will be asked questions regarding the nursing process. Maybe only one or two, but you will still be asked questions. But when you're asked those questions, those diagnoses will be fresh in your mind and you are able to use examples of patient care scenarios in which you've used those diagnoses. Implementation. Many intraoperative nurses working in the OR think most everything they do is implementation. And I can tell you, again, you work in all aspects of the nursing process. So you need to be able to differentiate the actions into where that falls within the nursing process. And we have evaluation. Now remember, the nursing process is very cylindrical. So it's a circle. It's not a straight line trying to get to the end of the finish line. Evaluation is analyzing the success of the goals. So let's do a couple practice questions. A patient who is scheduled for surgery exhibits signs of severe anticipatory anxiety reaction. Interventions for this patient should focus on A. Confronting the inappropriate behavior. B. Providing a quiet, unhurried environment with soothing words. C. Setting limits for his or her behavior in a firm, responsive manner. Or D. Assuring the patient that he or she has nothing to worry about. Now remember, as you're doing these questions, you want to practice the skills of being a good test taker. So initially, when I read that question, or when you read that question on your computer screen, you should have formulated an answer in your mind, drawing from your own knowledge and experience. And then, of course, you always want to read all four responses. Even if the first one or the second one meets what you formulated in your mind, you always want to read all four responses. Then keep in mind some of those tricks that I taught you. You know, if you lived in the perfect AORN guidelines world, if you lived in a perfect Joint Commission standards world, what would the answer be? The longest response is typically the correct response. Avoid choosing any answers that have all, none, always, never, any of those excluding words, because it just doesn't typically happen like that. And then if you're unsure, just mark it and come back to it. On the test, you have that ability to do that. So get in the habit when you're actually practicing the questions as you go through and study. So the correct answer, of course, is B. So providing that quiet, unhurried environment with soothing words. The person responsible for obtaining the informed consent for the surgery is the A. Perioperative nurse, B. Surgeon, C. Anesthesia provider, or D. Resident. course, the correct answer as far as informed consent is the surgeon. Now, many times the surgeon may delegate by writing an order to have a consent signed. And so when that surgeon delegates the responsibility of having that piece of paper signed, that is not informed consent. All you're doing is having a patient sign the piece of paper for medical liability purposes. Because for medical liability purposes, we like a consent to be in writing. But that is not the process of informed consent. The other point that I want to bring up here is that if you are the registered nurse and the surgeon has delegated the responsibility of having that piece of paper signed, as we know, being deemed the consent, you want to be prudent in your assessment of that. Certainly, it's not your responsibility to perform informed consent, but if you ask the patient, oh, tell me please what eye that you're having surgery on today, and the patient says, well, I have no idea. You know, I kind of forget. I need to have both of them done, so whatever you all think. That's not appropriate. Or if the patient says, I don't know, the surgeon just told me to show up here today and that I was going to have some type of procedure. Then you need to do due diligence, call the surgeon and say, I don't believe this patient has proper informed consent, and I'm not going to have them sign the consent until you come and answer all their questions, and the patient can actually tell me why they're here, for what procedure they're here, or what the laterality. So be prudent in that. The other thing that I like to bring up here is witnessing a consent. When you actually witness the consent, all you're doing is witnessing that it was actually the patient that signed that and the patient that dated and timed that. You are not truly signing that the patient was informed. But again, you worked really hard for your RN license, so you want to make sure due diligence. If a patient isn't informed, I wouldn't necessarily witness even to their signature. So, question 3. When performing the physical assessment on a geriatric patient, the perioperative nurse notes normal physiological changes in the respiratory system that include. Well, perhaps if you're not familiar with the respiratory system and the geriatric population, this might be a question that you just skip. And you just really don't want to spend your time trying to figure out something if you're unfamiliar with the information to begin with. So the first time that you're going through the test, go ahead, if this is not something that you normally would know off the top of your head, mark it and come back to it. Don't waste your time the first time going through the test to try to decipher the information. Because when you come back to it and you have that time to actually spend looking at these responses, I'm thinking you're smart enough that you would get this right away. So let's go through the responses. A says increased respirations. With a geriatric patient, normal physiological changes includes that their breathing actually slows down a bit. It does not increase, so they do not have increased respirations. B, increased vital capacity. No, they do not take these great, big, huge breaths for increased vital capacity. Their vital capacity actually decreases. So C, increased airway muscle tone. Well, unless a geriatric patient tries really hard and works out on a regular basis, there's actually no muscle in their body that increases in tone. So C is incorrect. And that does leave us with D being the correct answer. That geriatric patients do have increased chest wall stiffness. They don't have as much compliance to their chest wall. And so that's the other reason why you should be very careful giving a geriatric patient fentanyl. Because fentanyl actually can cause chest wall stiffness in anyone. And so when you give fentanyl to a geriatric patient, they have a twofold whammy with the chest wall stiffness. And they're not going to be able to take as large of breaths. So question 4, a 7-year-old male patient is scheduled for bilateral hernia procedure. The patient attended the perioperative pediatric program and has had a tour of the surgery unit. The patient's anesthesia induction would be facilitated by A, restraining his arms until he passed out through the excitement phase, which is phase 2, delirium. B, telling him that big boys do not cry. C, a quiet atmosphere of soft voices. Or D, telling him that he is being put to sleep. Well, C is the correct answer. And it would be the correct answer whether this was a 7-year-old or a 70-year-old. If you have somebody that is extremely anxious, or if anybody, that's why when a patient comes into the operating room, we need to be very cognizant about how much noise we are making. And we really provide that quiet atmosphere, provide soft voices for them, turn the blaring music off during that time, and really concentrate on the patient. So A. Now, unfortunately, if you're doing an awake, if you're inducting anesthesia by mask induction, there might be a time actually when you do have to hold the patient, but certainly not restraining him in a very forceful way as response A almost portrays. And then B, of course, is not appropriate. And then D, the issue with D is many school-age children, when we think about specific age, specific care, many school-age children may have had an animal that was taken to the vet and put to sleep, and they recognize the fact that when that animal was put to sleep, they never came home again. So that's why you don't want to use that terminology if you're going to be put to sleep. You can tell a child that they're going to take a nap or they're going to go to sleep like they do at night, but then they'll wake up and they're going to go home later. But you just wouldn't state that they're going to be put to sleep because of perhaps their past experiences with an animal. So question 5, a patient is scheduled for neurosurgical procedure. Which of the following nursing diagnoses should be given priority? So I can tell you, in certain situations, every single one of these responses is correct. There's a risk for impaired urinary elimination, risk for disturbed body image, a risk for impaired tissue integrity, and there's also a risk, and sometimes with perioperative positioning injury. So which one is the best answer? So when we think about neurosurgical procedures, we are contortionist with some of the positions in which we will place the patient. And so the best answer here is D, the risk for perioperative positioning injury. All the others may occur, but there is more of a risk, a greater risk for positioning injury with neurosurgical positions. The systematic and ongoing collection of data used to make judgments and predictions about a patient's response to illness is known as A, assessment, B, diagnosis, C, planning, or D, evaluation. And of course, this is just knowing the definition of assessment. It's collection of data. So this is a very basic question that's really testing your memory. Do you know the definition? So assessment, the collection of data. An example of an intervention performed during the planning stage. So remember, the planning stage is the necessary steps to achieve the goal. That's the definition of the planning phase. So an example of an intervention performed during the planning phase of the nursing process would be A, document the patient's progress towards achievable goals or achievable outcomes. B, communicate intraoperative information to significant others. C, evaluate the effectiveness of the plan of care. Or D, assess the psychosocial status of the patient. So this is during the planning phase, the necessary steps to achieve the goal. And B is actually your correct answer. It is the best answer. So you want to communicate intraoperative information to significant others. Now this significant others is meant to be team members. So this is that we're communicating among all the members of the surgical team any pertinent information, and that would be in the planning phase. So question 8. During the evaluation phase of the nursing process, the perioperative nurse, A, assesses patient data to formulate a diagnosis, B, identifies outcomes unique to the patient, C, develops a plan of care, or D, documents the effectiveness of the interventions. So evaluation is how did we do in achieving the goal? And evaluation doesn't always have to include documentation, but it typically does. So D actually is your best answer, because all the others, if you look, A tells you you're assessing. B, you're identifying outcomes. So with identification of outcomes, that's part of the nursing diagnosis. C, you develop that plan of care. Again, planning, plan of care, you're developing that necessary steps to achieve the goal. So D is the only one to document the effectiveness of the interventions that we've already provided. So that's the evaluation phase. Question 9. The provision of appropriate supplies and equipment needed to perform a procedure is an example of A, outcome identification, B, implementation, C, planning, or D, evaluation. And it's actually C, planning. The provision of the appropriate supplies and equipment. So that's the provision of those. So you have the central sterile processing staff, or maybe the OR staff is even responsible to pull the supplies for the surgical case. So that's the provision of the supplies, that's planning. Now when you bring the supplies into the operating room and you start opening those supplies, that's implementation. So having the supplies, planning, opening the supplies and getting ready for the case, implementation. That's it. Thank you.